right, thank you. Thank you to, as Luke said, I am the program director for the University of Iowa Perfusion Education Program. Thank you to the CPC from Sanibel for asking me to speak on a topic that I am very, very passionate about. And thank you for being in the chairs and not in the sun working on your tan. I know that we all want to do that, but instead of that, we're here trying to learn. We're supporting Sanibel and the speakers, but we're trying to make a difference for our patients, and that's what's important here. So thank you for being here, even though it's beautiful outside. So my objectives here today are to discuss three main points. I want to talk to you a little bit about patient safety, adverse events, as well as protocol use. We'll talk about the expenses and challenges associated with patient safety. We'll talk about a definition and the expenses again of adverse events. And then with protocols, I'll talk to you a little bit about how to do it and where your resources are. So when learning something new, I always love a good, true multi-definition. So much now that I actually love to read on a Kindle because I can look up the words instantaneously. However, there's nothing that replaces the good smell and feel of a book in your hand. If you get what I just said, you're either a fellow reader or you think I'm weird by slide 5, and that's okay. I'm okay with that. Because at the end of this presentation, some of you aren't even going to like me anymore, and that's okay. So let's start here with what is a protocol. So the definition of protocols is, there's 3 of them here. It's a detailed plan of scientific or medical experiment, treatment, or procedure. It's also a set of predetermined criteria that defines appropriate clinician interventions that articulate or describe situations in which the clinician makes judgments relative to a course of action for effective management and common patient care problems. And then according to the WHO, the definition of a protocol is the absence of preventable harm and the prevention of errors/adverse events in healthcare. So protocol use. We don't have ARS here, so I'm just gonna ask you with a quick raise of your hands, how much of your daily clinical practice is based on the use of institutionally specific protocol use? So 100%, meaning we have so many protocols we don't even get to think on our own. Greater than 50%, we have some, but we still have more work to do. Or protocol what? So raise your hands, which, are you 100%? Anybody 100%? Okay, we've got some. Greater than 50%, but you still have more work to do? Yep. And how many don't even know what a protocol is? Oh, good. Okay. So we're headed in the right direction. So what do successful organizations look like? They often have similar specific traits. They have standardization of practice through the use of policies and protocols. But they also have a mindfulness within their organization. This usually comes from a champion. In my experience, it has always been a specific surgeon who is the champion for this. But this champion in this environment, within this culture, they have an awareness of where they are, where they need to be, where they should be, and where they want to go. They often have, these teams have respectful, safe, and learning environments. This is where the multidisciplinary trainings come in. I don't know if any of you have been able to attend one of those, but those are fantastic events. And the programs that support the multidisciplinary training, those are the ones that are successful. And in order to have this, and when we have these environments, this is when the staff has a positive perception of their safety, their teamwork, their leadership, all of it. But what happens is at the end of the day, the leadership has the ability to see that this is where they need to be. And the discussions and everything about it not only prevent future errors, but they create the environment where safety is the top priority. And if safety for the patient is the top priority, we always win. So let's start with some of the economics of patient surgical safety. Regardless of how we feel about it, healthcare is a business. If the business doesn't do well, you don't get paid and we can't provide healthcare. In this paper by the Surgical Clinics of North America, there's a discussion about how the adverse events and the expense that they impact on healthcare. An adverse event is any sort of unintended consequence of action. It can be something huge, it can be something small. But what they're referring to in this document is about never events. And never events are exactly as they say, they're things that should never ever happen. And so it can be things like the National Quality Forum has determined, surgical events, wrong body part, wrong patient, wrong surgical procedure altogether. So huge things, right? But then it's also, if you read further down into the document, it also talks about things like contaminated and expired drugs. It talks about using devices for functions other than they were intended, and air embolism. And those are the things that are affecting us, right? Or have the potential to affect us. These are the never events that we need to be concerned about. And a sentinel event is an unexpected occurrence when serious injury or death occurs. And so the reason that we care about this is in 2007, Medicare decided that they would no longer pay for any additional costs that occur because of these events. And I could ask you right now if you've ever been in a procedure where you suffered an adverse event or a never event. And I'll tell you right now, if you haven't, number one, you're super lucky, but number two, you will. You will. And so we have to think about this and we have to worry about this because it's affecting our hospitals, it's affecting our patients, and it's affecting our hospitals. The other thing that they've done is the Joint Commission now, with the public reporting, the goal obviously was to increase accountability and improving quality of care, but what that's doing is letting the patients know how we're doing. And they're saying we're no longer going to pay for these mistakes. So as a hospital, you need to put checks and balances into place to prevent these from happening. So every year, excuse me, I've got that same tickle. Every year, they say that, or this document reports that every year 17.2 million surgical procedures occurred. 500,000 of them were open heart procedures. 7 million of them encountered adverse events, and 1 million ended in mortality. So when I get a lot of numbers, I try to put it into something that makes sense to me. So what these numbers mean to me, as Luke mentioned, I am the program director for the University of Iowa. So this means to me that I have two entire states of Iowa. That's how many adverse events we had just last year. Every single person in Iowa twice. And half of the state ended in mortality. Half of my entire state ended in mortality. Now, if you can't relate to Iowa because you think we still grow potatoes, then I can relate it to something else for you. How about the city of Boston? So last year, the entire city of Boston suffered an adverse event from a surgical procedure. The city of Austin, the entire city of Austin is gone. The entire city, just last year. So we have to do a better job with this, and we have to make sure that this is happening. Sorry, I lost my mouse here. The mouse is gone. So while he's working on that, so why do we care about this? We care about this because it's expensive, as I just said. So the latest report is that the US spends over $29 billion on healthcare and these adverse events that are associated with them. There you go. Thank you. Tech is not my forte. So you understand why the hospitals are taking action. So all of the healthcare reforms that we've been dealing with for the high quality patients with that physician scoring system that I talked about, and the fact that patients are asking more questions. We no longer have patients that say, well, I take this medication because that's what the doctor told me. No, they want to know why. They want to know how. They want to be involved in our care. I think we saw that with our wonderful guest speakers yesterday. You know, she became an advocate for her husband, and she demanded, she stood up and she looked up and she learned what the tests were, why they were being run, all of that. Our patients are now advocates for themselves. And then, of course, we have the issue of value-based insurance coverages. The insurance companies are now determining what we do brings value to the patients and whether they're going to reimburse it or not. Do you remember when they pulled the ECMO cannulation issues? I think it was like 2018, where depending on where we cannulated, they were going to determine whether we were reimbursed for it or not. Like, those are the things that hospitals have to worry about. I mean, ECMO programs freaked out when this happened, as they should, you know? So we have to worry about these things because it is so very expensive for our hospitals. So you can understand that our administrations have so many challenges to face. Thank you. Poor care is expensive. We're running additional unnecessary lab expenses. Those are expensive. And employees now are not only interested in education, but education is now mandatory and expected. All of the education that we provide, whether we're teaching our ECMO specialists, whether we're teaching competencies, whether we're teaching nurses, it's expensive and it adds up. It's getting more and more difficult for hospitals every year to ensure that their expenses aren't higher than their income. So in this editorial from The Lancet, I love to read The Lancet. I love medical papers and data and stuff too, but I also love to read The Lancet. And this author here ties in prevention and patient safety for us. And he challenges us in this article to talk about the fact that patient safety is improving, but we as a medical community are aware that we need to do more work in this area. And the fact that the adverse events that I'm talking about and that I'm referring to are absolutely preventable. And preventable mistakes are unacceptable. Preventable mistakes are unacceptable. There's some statistics in here that I found completely shocking. So worldwide, there's 1 death in every 300 patients that they suffer. Well, that statement doesn't make any sense. I have death and preventable medical accidents, but they die because of the medical accidents that are happening. And 1 in 10 patients suffer while receiving any form of health care in the United States. 1 in 10. So there's maybe 50 of us left in here, maybe 30. You know, that's a significant number of people that are going to have an adverse event. And again, it's back to the 15% of the hospital expenses that are incurred are the result of some sort of patient safety issue. And so this author helps remind us that we're not doing enough at this point, but it's not too late. So the healthcare profession has all of the checks and balances in place, all of the checklists, all of the safety devices. We have more technology than we can handle, and yet we are still causing preventable harm to someone's grandmother, loved one, or child. So you say, Shahna, what does this have to do with me? This has to do with you because you're a professional. As a professional, those financial stats that I shared with you should infuriate you. Your professionalism demands that you place the interest of the patients above the clinician, above yourself. And you do this by setting and maintaining standards of competence and integrity. Every case, every patient. So I ask you, what do you do when no one is looking? Competence and integrity are exactly some of the ethical principles that Varkey refers to in this study in the principles and clinical ethics of their application to practice. So now it's time to get real. He discusses that ethics essentially mean that you are acting in the benefit of the patient with prevention of harm to have the best outcome, and most importantly, that every patient is receiving the same care. Every patient should receive the same care regardless of geographical location. So you can see here that all of the parts that make us a professional, they balance at the bottom of our ethical principles and our morality. So what are you doing when no one else is looking? So sometimes I stand up here and you like what I have to say, and sometimes not. Today is going to be one of those days where you're probably not going to like me. But that's okay, because I prefer to get up here and do the work and challenge you. I love to allow you to take that second to think about your life and where you want to be as a professional. Today I'm going to challenge you and say that it is your ethical responsibility to incorporate clinical protocols in the operating room. Clinical protocols provide an environment for you or a structure for you. It is your moral obligation to ensure the safety for your patients. Protocols are the tools. They're going to help you reduce human error, and they help you achieve high quality care for your patient by minimizing error and continuous improvement through the use of protocols. I'm also going to say that it is your own personal integrity that determines your desire and motivation to incorporate protocols. You don't like that statement? It makes us uncomfortable, right? Your own personal integrity determines your desire and motivation to incorporate protocols into your clinical practice. I don't want any more excuses. I have been giving talks on protocols and standards and guidelines for years, Many of you have probably heard me before. And every time I have a workshop or a protocol or a presentation, all I hear is, no one would use them anyway. I work too much. I don't have the time, all of that. I hear all of that. Just yesterday, I heard a funny story at one of the restaurants here. Nah, we don't even have protocols. You would hate it there. It's like the wild, wild west. I kind of laughed, and inside I was dying, right? Because I'm like, how is that acceptable? In this day and age, how is that acceptable? Now, people hate protocols. People hate change. They hate being told what to do. And in fact, most of the time when I bring up writing protocols, people will look at me like this. Is it clicking? There you go. No thanks. Nope. Or sometimes like this. That it? They'll be sitting on their phones for 45 minutes in front of me, and the second I bring up protocols, they're out. They will literally leave the room and stop talking to me. Or they just scream running, I'm not interested. Yeah, usually it's a hard pass, right? Right? That's what I face on a regular basis. It's okay. It's okay. But you guys, the use of institutional protocols is vital to patient safety because we work in an environment, as you know, in the operating rooms where there is huge catastrophic events that could be taking place with catastrophic consequences. We actually have the ability to kill someone. So we have to ensure that our potential problems, any sort of issue that we might have, are anticipated, detected, and managed early enough to prevent that catastrophic event. And the way that we do that is through prevention. So using protocols, clinical procedure guidelines, AmSECT standards and guidelines will help you prevent those never events and help decrease all of the costs involved. As I stated earlier, I believe it is your ethical responsibility to use protocols in the operating room. Prevent mistakes with the use of the tools that are available to you. Okay, all right, Shahna, you've convinced me and you've challenged my integrity and morals enough for today, right? How do I get started? So the first thing that you have to do is you have to reach out. When I first started this project, I was met with a little bit of resistance. Some people, institutions would say, well, this is blank, property, you can't have it, we won't share. But I tell you what, this project has been going so long now, people are understanding that we need to use this and we need to share, because at the end of the day, we're all here for patient care. And I have so many people that if they can't legally share it, they'll take the logo off and they'll just put it in a Word document. But we have such a great committee of people working together to improve patient care now that I guarantee you can find them. So just reach out to your friends, reach out to your past classmates or your coworkers. There's some resources like the clinical practice guidelines that we can trust is a great document. You can get into the ERAS, the Enhanced Recovery After Surgery, to help you have the right information to write a protocol. You can use the internet, right? Everybody loves a good Google search, PubMed, clinicaltrials.gov, all of those. But the best reason that I'm here today, and the best news, is that I'm gonna talk to you about using AmSECT's toolkit. As you may know, I have been part of the ICBP AmSECT committee since 2012. And our mission, everything that we do, every week that we meet, we work, and our goal is to continuously improve the delivery of care and outcomes for our patients. I'm here to show you how AmSECT's toolkit is going to help you reduce errors and improve your patient care. I'm sorry, one second. All right, we have created an area for you on the AmSECT website, and it has all of the tools that you need. So today we'll talk about Perfusion clinical resources, that's the PCR. We'll talk about the adoption of them, the implementation of them, the personalization, and then the renewal process. Before I go any further, I want you guys to understand that these documents are available for every perfusionist. These are not just for AmSECT members. Now, if you're not an AmSECT member, shame on you, but that's a whole nother talk for later. Well, we better keep going before you start throwing your coffee cups at me or something, but first I challenge your personal integrity. Now I'm gonna tell you where you should spend your hard-earned money. I mean, who do I think I am up here? But seriously, it's literally $225 for you to join AmSECT. Like, you spent more than that at Charlie's last night. I was there. I know you did. And then committee work. If you want to talk about the committee work, I can help you with that as well. But let's get focused here. Let's focus on the website. So as I said, AmSECT's created Perfusion clinical resources for you. So we have documents under here that were created by perfusionists for perfusionists, okay? By perfusionists for perfusionists. And our goal is to help your teams reduce any adverse events, improve patient care through the use of AmSECT standards and guidelines, clinical procedure guidelines, and protocols. So you can see here under the resources tab on the front, free for everybody, like I said, Perfusion clinical resources. Now these documents here, you can see we've got all three of them labeled here: AmSECT standards and guidelines for perfusion practice, clinical practice guidelines, and clinical protocols. All three of them are available, but the thing that I want you to understand is that, yes, my assignment today is to talk to you about protocols, and that's what we'll focus on, but these three documents were created with complete different intentions of use. And we have, this is literally pulled from the website in case you're gonna go take a look at it. But they have different levels of evidence, and they have different intentions as well. So if you have questions about the other ones, we can talk about that at the mic, or we can talk about it afterwards. But today, we're gonna focus on the clinical protocols. But what I'm gonna do is show you here how they intertwine. This is a great example. So when we created AmSECT standards and guidelines for perfusion practice, we intentionally made standard 1 to read that as a mechanism for applying each standard to clinical practice, an institution or service provider shall develop and implement operating procedure for each of the standards. So this is not a recommendation. We are not suggesting that you do this. We are saying that you must do this to ensure that you are fulfilling the minimum safe requirements for cardiopulmonary bypass. I also love to discuss the difference between shall and should, in case you want to hang out and talk about that later too. But you have to understand the difference between the documents. So you can see here, we have an explanation on the website as well about the clinical protocols. The clinical protocols are created from other people's protocols, like I told you, reaching out to your friends, published literature, they are evidence-based, but also committee consensus. I have been in this profession long enough. You know, I love data, I love papers, I love to read science, but I also do not think that there's a replacement for clinical experience. And I think that clinical experience is where this comes into play with the protocol used. So the key word here, when you're looking at these documents, is that we've created these to be a template. Our goal was not that you go to the website, print off the protocols that we have, put them in a book, and let them collect dust for the next 10 years. They are a template. You will find in them a little bit of an introduction to the science, specific procedure guidelines may be associated with that special patient population, and then some more information that you fill in and make them institution specific. You know, I cannot write a document that fits your program. You have to write that. You have to sit down and write one that's specific for your program. So these are the 10 that we have available right now. And I forgot to mention too, these are also have been through legal, and I'll show you a little bit more of what I mean by that. But these are the 10 that we have available: acute normal volemic hemodilution, antiphospholipid syndrome, angiomax use, bleomycin, cold agglutinins, heparin-induced thrombocytopenia, Jehovah's Witness, malignant hypothermia, pregnant patients, and sickle cell. So we chose to go with these special populations because, well, they were kind of the easiest for me to get started with because they don't really change much institution to institution. Like, for instance, a priming protocol is probably going to look different for everyone. But a pregnant patient, we basically all need to do the same types of things. So this is where we started. These 10 are on the website, available for you right now. And again, you can go, you can click on it, you can find basic information. You can find a couple perfusion-specific tasks that go along with it, and then the rest of the stuff that you need to fill in. So I'll show you here just a quick example of the Jehovah's Witness one. So you can see how we broke it down. When I'm referring to the legal stuff, this page shows you at the top some of that information. Our legal team through AmSECT was available to help us create the intent of how this should be used. And the concept is that is the stuff that is always there, every protocol that you write. Your institution, whether you know it or not, has a template. Every time I've started a new job, I've had to go find that template. It's not always easy to find, but every hospital will have one. And then you take the information, and they all should look the same, they should feel the same, they should have the same legal information on it. So this is an example of one of it. You can see the intent in this is to be a resource, not a replacement for institutional protocols. So yes, it is provided to you by AmSECT, but it is your responsibility to then take your final documents through the legal system within your hospital. So for Jehovah's Witness, we have a title, easy enough, purpose, target population, and a little bit of definitions. We move on to the policy. The surgical team will ensure all necessary steps are taken to honor the religious beliefs of the patient. Perfusion pump considerations. So depending on what document you're talking about, this is a short section or it's a little longer. Sometimes there's a lot of things that we need to do, sometimes there's not. We also include a procedure section, and this is the most specific. This is where you would take this information and you would decide with your teams what is appropriate and what is not for your specific institution. You know, how are you going to do this? What labs are you going to run? How are you going to put this into place to make it work for you? And then, of course, we like to include related documents. So if some of your protocols are similar, or like when you're priming, and you should refer to your cardioplegia protocol, you know, they should intertwine and they should interact with each other. And then, of course, you should always have references. The latest rule that I learned from Mr. Stammers was it should be nothing older than 7 years. And we'll get into why this matters later. This section right here, the disclaimer, was also written by your legal team. So it is meant for you to take this document, copy this, and keep it in your protocols. And basically what it says is that this is what we're doing. We're trying to provide the best patient care possible, but there are times when we will go without following this protocol. And that's science, right? We all know that. That's the way it works. At the end here, you have an option to fill in who would work for you. I'll be honest, sometimes this is the hardest part for perfusion programs, is finding out who actually should sign their documents. Some places, they just need the chief of perfusion and the medical director. Some places, you have to go all the way up to the CEO. Usually, it's a lot of people that don't know what we do, and so it actually sparks other conversations, which has turned out to be fantastic. I'll give you a quick example. We were writing our anticoagulation protocol, and it went from a few perfusionists having a discussion on it, to anesthesia, to the surgeons. We ended up getting the entire pharmacy department in on this protocol, which was fantastic because they are the ones that should be available to back us up and provide the information. And so not only did it take a lot longer, but it ended up being such a better resource for our department. We have a lot of work to do, as some of you just raised your hands and said you did as well, but this is where we have to start. So you get your signatures and you figure out who endorses it. So let's see where we want to go next. We're going to talk a little bit about personalization, having a plan of action, the implementation of them, as well as a renewal strategy. So now that you've seen some of the examples, let's talk first about personalization. Full disclosure, all of this work was inclusive and requires teamwork participation. I was interested in starting this project, but I have not done this alone. If you were at AmSECT a couple of weeks ago, you may have seen this video. A friend of mine, a very awesome coworker, Tiffany Robb, does some fantastic work with protocol work, and she's very techie. And she also created this video with one of our friends from the quality committee, Matt Mosca, and he'll give us this video here, if it's going to work for us.
When there is not an established protocol template for the specific policy you are looking for, you may have to craft a protocol from scratch. Now, writing a well-written protocol from scratch comes with experience. However, if you include these main elements, you will be well on your way to constructing a more complete protocol. At minimum, this protocol must include header elements, title, authors, date, also background and purpose, policy procedure, references, and approvals. You may choose to add additional elements if it is applicable to your protocol.
So when you're getting started, it sounds really simple, but all you have to do is come up with a plan of action. Define your goal and figure out what you want to improve. I guarantee that every single one of you looking at me right now is thinking about something that you could improve in your institution. And you just begin jotting down your notes, and you start your research and you start your writing. Here's a little checklist. I love checklists. You can see here, you just identify your need, determine what you need, figure out who your administration is. You go all the way through your research, all the way down, and you have to identify your stakeholders, which we'll talk a little bit more. And then, of course, submit for approval, whatever is right for your institution. So you basically use your checklists, and you get to work. One of the most important things that you can do before you start writing your protocols is figure out who's going to be, again, I'm using that word, your champion. Who's going to help you? Who's going to back you up? For me, again, it's always been a surgeon or a medical director that's helped us. And if you find that right person, they're the one that can help point you in the direction of the right people to talk to. All the hospitals also have a quality and safety coordinator, and they love protocols even more than I do. So they will help you write them as well. And then you just research, and you write, and you review, and then you write some more, and then you review some more. And then again, you have to get the approval, the final sign-off. Your surgeons should be involved in the creation of your protocols. This is not something that a perfusion department should be doing on their own, because remember, they are the physicians. We are working under the direction of the physician, and the physician should be a part of the protocols. Now, I get it. You guys are looking at me and you're like, okay, sure, my surgeon's not going to be up for this, right? But just because that's the way we do it doesn't mean that it's right. So it's your job to get out there and stand up for your patients and get your physician involved. Keep bugging them until they don't want to hear about it anymore. So if your team is new to protocols, perhaps you're still stuck in the wild, wild west like that other team, you have to talk to them about the importance of emergency situations, how protocols can help you do better. I think someone was talking about they had a training recently where they did oxygenator change-outs, and the staff member didn't want to do it, thought it was ridiculous, didn't want to participate in it, and then less than a month later had to do one, and he ended up backtracking himself and saying, I apologize, I'm really glad I got to go through with that. And so you have to have these discussions. You have to talk about the value of having protocols for your special patient populations. Those are the ones that we don't see all the time. We don't have a cold agglutinin patient every day. We don't have a pregnant patient every year. So if you have a protocol, you can have something that refreshes your memory. Okay, I remember these are the things that I'm supposed to be thinking about and taking care of, and I know that my physician has already approved it, so we're all on the same page together. And then, of course, protocols are great for training. I have always worked with students. I've always worked with grads from the clinical arena, and they do so much better when they have protocols and procedures in place. They know what to do, they know what's expected of them, and they succeed so much better. I've worked in places that have tons of protocols, and I've worked in places that have none. And I can tell you there is a significant difference in the happiness of your students if they feel prepared and taken care of. And then, of course, if they're still hanging around while you're still talking about protocols, you can talk to them about patient safety and the reduction in costs. Now, I know I'm not naive. I understand there's going to be barriers to the implementation of these protocols. We talked about having the team accountability and the buy-in. Have some workshops, have more than one person work on them. This really shouldn't be the job of just the chief. Every perfusionist on your team should be assigned a protocol. Let them have some buy-in. Let them see, first of all, how hard it is, how much time it takes, but also, it helps them have an investment in the production of this product. And you have to engage your leadership. I've said that a couple times now. You need to have a champion. You need to find out who your people are that can help you. And as I mentioned, you have the National Society on your side. AmSECT is here to support you and to provide you with the protocols that you need. Some of you might have pushback from surgeons. I also live in that world, and that's okay, because that's why that evidence-based research comes into play, which is why, and I'm bringing it back to, you need all of those documents to be successful. A clinical protocol should not exist alone without the use of clinical procedure guidelines, as well as AmSECT standards and guidelines. So they're different documents with different levels of evidence and different uses, but they're meant to be intertwining together. And then, of course, red tape. And that's where you get your QI friend on board. And again, they love protocols. It's a good time for them. Excuse me. So please understand that when we wrote Standard 1.2, we wrote this with patient care in mind. Again, it's important to understand that you should not be writing these protocols, putting them in a binder, and putting them in the corner. Okay, that everyone knows, oh, where's the protocol book, right? These are active living documents, as is medicine, right? So part of your responsibility is that by the time you write, for instance, the 10 that are out there, and then we're working on the next set, those other 10 need to be updated. So this is what I was talking about with the Al Stammers saying, 7 years for the research documents. Your evidence, if your documents, your references are older than 7 years, you need to update them. But you also should be reviewing, is this still how we're practicing? Is this still the most important evidence-based medicine in relation to these special patient populations? So you need to continuously be working on your protocols. This is not a project that's going to be done quickly. And so that's why we wrote Standard 1.2 to say that they should be reviewed and revised annually or more frequently when deemed necessary. But don't forget, these are living documents. So in conclusion, I just really think it's really important that we work together, collaboration, multidisciplinary, to promote this culture of safety so that our teammates can feel safe, they feel like they work in an environment where they can speak up, and the most important thing is that we remove these preventable errors from healthcare. You want to keep your knowledge current. You have to have benchmarking. I think someone said also you cannot measure what you are not keeping your data on, right? If you don't have data, if you're paper charting, like us, you have no data. You cannot prove how your patients are doing. Just because they may get out of the OR doesn't mean they're doing well. So you have to make sure that you have quality improvement, standardization of care, so that you can measure the outcomes for your patients. And I know, and I remember, change is difficult. Use the toolkit that AmSECT has created for you to help your patients do better and help your patients have an improved outcome. So these, I'm excited to let you guys know, we have 5 already in legal again. They've been there for quite a while, so I'm not sure how much longer it's going to take. I don't have any control over that, but the next 5 will be released. Deep hypothermia circ arrest with antegrade and retro cerebral perfusion, vacuum-assisted venous drainage, left heart bypass, massive air embolism, and oxygenator change-out. So those are the next 5 that will be out. And I always like to take this time to, number one, if it's something that protocols interest you, and you want to help write, or you need one specifically written for your program, that's how we find out what is needed by our community. Again, we are just perfusionists writing for perfusionists. So if there's something that you need, please reach out to us. We want to provide you with the tools to make you successful. So I just want to say thank you again to the CPC for the invitation to come talk about protocols. If you have ever used a protocol, donated a protocol to our committee, helped write a protocol, discussed a protocol with me and didn't run, if you've provided a reference, or if you've created protocols for your team, I just want to thank you for being in here, for listening and learning and trying to make a difference for our patient care. If you have any questions or concerns, and you still want to talk about protocols or, the words shall and should, I'm your girl. Thank you for your time today, and thank you for being in this room.